Moving on now to coronary artery disease, consider what hypertension, peripheral vascular disease, and coronary artery disease all have in common. Primarily, it is the etiology of atherosclerosis. The plaque not only narrows the lumens of the blood vessels, causing hypertension, but it also creates a potential for the plaque to rupture into either a thrombus or an embolus, and either totally or partially occlude the blood vessel. CAD is the most common type of heart disease and the leading cause of death in the United States in both men and women. Hardened and narrowed arteries can reduce blood flow, causing ischemic conditions which lead to anginal chest pain. If the ischemia lasts long enough, which is usually greater than 20 minutes, infarction and tissue necrosis can occur. An acute MI occurs when a blood clot suddenly cuts off the heart's blood supply, causing permanent heart damage and possible death. When talking about CAD, we need to distinguish between the terms ischemia and infarction. Ischemia occurs when there is an insufficient amount of O2 supplied to the heart muscle, but by resting, balance is restored and no damage occurs. Infarction, however, is when there is necrosis or cell death due to prolonged ischemia. Angina pectoris is a type of chest pain caused by ischemia that is limited in duration and does not cause permanent damage. The pathophysiology, as I said, is the buildup of atherosclerotic plaque, which typically occurs in the large and mid-sized arteries, causing occlusions and hypoxia to the tissues. Plaque can be stable or unstable, and either way, it can rupture without warning, causing the sudden formation of a blood clot, which will lead to either a total or partial occlusion of the artery. There are many different types of chest pain that patients experience, and so we need to be able to identify the chest pain of an acute MI. Chest pain that occurs with raising the arms or with deep breathing is more typical of musculoskeletal pain or pericarditis, and not coronary artery occlusions. Stable angina is defined as chest pain that is relieved within 15 minutes by rest or by taking nitroglycerin tablets. Chest pain that lasts for 20 minutes or more and is not relieved by rest or nitroglycerin is more characteristic of an acute MI, and the patient should receive immediate treatment. Chest pain is further classified as either chronic stable or unstable angina. Chronic stable angina occurs with moderate exertion in patients with a stable or fixed plaque. The frequency, duration, and intensity of the symptoms remain the same over several months. Chest pain results only in slight limitation of activities and is relieved by rest or nitroglycerin tablets. The fact to keep in mind is that chronic stable angina can become unstable and evolve into an acute MI. So if the patient reports more frequent chest pain, their stable plaque may have fully occluded and they've progressed toward the acute coronary syndrome. Unstable angina is on the spectrum of acute coronary syndrome, which we will cover at level 4. But you need to understand this transition between stable and unstable angina. Unstable angina can occur at rest or with exertion, and it causes severe activity limitations. It can present with an increase in the number of attacks and in the intensity of pain. The pain or pressure may last longer than 15 minutes and be poorly relieved by rest or nitroglycerin. If it is truly unstable angina, the troponins and other biomarkers will be negative, and ST changes will either be minimal or not there at all. So it looks and it feels like a heart attack, but it's not a heart attack. The big however is that we never assume chest pain is only anginal pain. If it is not relieved within 15 minutes by rest or 3 doses of nitroglycerin. Blood biomarkers such as troponins must be drawn and a 12-lead EKG done to rule out acute MI. Unstable angina is categorized in 3 ways. The first is new onset angina, which is the first anginal attack that a patient has that occurs with exertion. Testing and diagnosis should be done immediately. The second category is vasospastic. This is called variant or Prinzmetal angina. The coronary arteries may have atherosclerosis, or they may not have, but an underlying inflammatory or autoimmune process causes them to vasospasm, which means that they contract, reduce blood flow, and cause ischemia, which causes chest pain. This type usually occurs at night while sleeping or early in the morning. And lastly, unstable angina is characterized as a warning sign or pre-infarction signaling an acute MI in the near future. Infarction and necrosis will occur when blood flow is reduced 80 to 90%. All unstable angina should be treated with rest and 3 tablets of nitroglycerin 5 minutes apart. If pain is not significantly reduced, the patient should receive emergency medical treatment. This slide shows you a spectrum of clinical presentations of impaired perfusion to the coronary arteries. Chronic stable angina occurs with a stable plaque leading to mild ischemia with exertion that is relieved with rest and/or nitroglycerin. Unstable angina is due to ischemia to different degrees to the myocardium and continues even with rest and/or medications, but has normal biomarkers. And unrelenting chest pain with ST elevation indicates an infarction. Necrosis due to prolonged ischemia and will have positive biomarkers. Symptoms of CAD differ between men and women and among diabetics. The classic symptoms of chest pain are tight pressure within the chest or like an elephant sitting on the chest. Jaw pain is experienced with pain radiating down the left arm. Pain may also present with shoulder or back pain, sweating, indigestion or heartburn, nausea or vomiting, dizziness, and rapid or irregular pulse. Women with CAD may experience the classic symptoms, but they are also likely to present with less commonly recognized symptoms such as unusual fatigue, sleep disturbances, shortness of breath, indigestion, and anxiety. Diabetics also display atypical symptoms such as nausea or indigestion. Nurses need to ask the right questions when a patient has chest pain. First off, you need to frequently reassess, and if they are having any chest pain or tightness, ask about the onset location, characteristics, duration, what brought it on, are there any associated symptoms, or is pain made worse by something or pain relieved by something. We need to also assess for shortness of breath, orthopnea, fatigue, cough, cyanosis, edema, or nocturia. We need to ask about family history and personal habits of smoking, alcohol use, or drug history. A priority for the patient is to diagnose or rule out whether an acute MI is occurring so that reperfusion therapy can begin as quickly as possible if needed. ECG changes occur very rapidly after an acute coronary artery occlusion, and a 12-lead EKG should be obtained as soon as possible. Troponin levels won't rise until after about 3 hours, and the myoglobin elevates in about 1 hour. All of these lab values are affected with an acute MI, but the troponin is the most sensitive. If the initial cardiac enzymes are measured too quickly after symptom onset, they may return as negative. The blood test should be redrawn to be within 8 to 12 hours after symptom onset to see the true rise and peaks. Because signs and symptoms for unstable angina are similar to having a heart attack, the protocols of MONA will be started while ruling out acute MI with other diagnostics. First priority is to determine if the patient needs any oxygen, because a major problem is that O2 isn't being perfused to the myocardial muscle cells. However, O2 should only be given if the SATs are 94% or less. Nitroglycerin or aspirin would be the next thing to give. Nitroglycerin tablets are placed sublingually under the tongue to be dissolved. Repeat the dosage every 5 minutes times 3 over 15 to 20 minutes. The nitroglycerin can cause hypotension, so blood pressure must be rechecked between each dose. Sometime between the nitroglycerin tablets, you can have the patient chew the aspirin. If the blood pressure is stable and the patient still has chest pain, morphine can be given cautiously. All nitrate administration is contraindicated in patients who are using phosphodiesterase inhibitors such as Cialis and Viagra. This is because of the risk of severe hypotension caused by the vasodilation. We need to be very cautious not to cause hypotension because that can severely compromise any remaining perfusion to the heart and possibly cause the patient to crash. If an acute MI is ruled out, the patient will be scheduled for further diagnostic workup such as an exercise or chemical stress test and an echocardiogram. For patients with increasing symptoms or with a significant amount of myocardium that is ischemic, a cardiac catheterization will be ordered. Cardiac catheterization and coronary angiography provide images of the coronary circulation, and they can identify the location and severity of any blockage. During a PTCA, percutaneous coronary angioplasty, plaque can be scraped, roto-rooted, compressed, or stented to open occluded vessels. Entry of the catheter is through the large femoral artery or radial or brachial artery. The patient is at risk of bleeding from the arterial access site post-procedure, so the nurse must immediately assess the access site as well as assessing the patient's vital signs, and then she must frequently reassess. Risk factors for CAD are the same as they are with hypertension or PVD. Lipid panels show high LDLs, low HDLs, high triglycerides, hypertension, smoking, tobacco use, diabetes, insulin resistance, obesity, lack of activity, high sodium intake, and etc. Patients diagnosed with metabolic syndrome have a greatly enhanced risk of developing cardiovascular disease. It is diagnosed with 3 or more of the following measurements: abdominal obesity, which is a waist circumference of 40 inches or more in men and 35 inches or more in women, triglyceride level of 150 or greater, low HDL cholesterol of less than 40 in men, less than 50 in women, the systolic blood pressure of 130 or greater, or a diastolic blood pressure of 85 or greater, which is hypertension that is not all that high, and then a fasting glucose of 100 or greater. So we need to teach and live a healthy lifestyle. Remember that primary prevention is preventing the occurrence of CAD, which is done by eliminating unhealthy habits and initiating healthy habits, such as eating a heart-healthy diet, exercising, and maintaining a proper weight. Secondary prevention is to prevent the progression of CAD, which can be done by teaching patients to slow down or take rest breaks if physical exertion triggers angina. Avoid large meals and rich foods that leave a stuffed feeling if heavy meals trigger angina. Patients need to learn ways to handle stress. They need to take their medications as prescribed, such as the antiplatelets, antihypertensives, and statins, which are also called antilipemics. Also by monitoring blood pressure and improving the lipid panels. Tertiary prevention focuses on minimizing deterioration and improving quality of life. Angioplasty and other procedures can be the starting point for a patient to move toward a healthy lifestyle.